Good morning, and on behalf of Department of Internal Medicine, I welcome you all to the first Saturday clinic meeting of 2025, and with that, I wish you a very prosperous new year, full of academic feast. Today's case is an interesting case. It's a diagnostic challenge, and some of you may actually encounter them. A little rare in India. The idea of today's case presentation is to give you an idea of on how to approach a case rather than stress on the diagnosis. Without further ado, may I request Major Parvinder, please.
Good morning, everyone. My patient, 31 years old male, resident of Deoghar, Jharkhand, posted in Jodhpur, educated up to 12th standard, a serving soldier trade, driver by trade, right-handed, informative self and reliability is good. He presented with the complaints of facial weakness since 30th of October and weakness of all four limbs since 5th of November 2024. Onset was acute and it was gradually progressive. The patient was...
Can you go back one slide, please? Any resident, first year resident, can tell me what is the relevance of the presenting complaint and onset course? Anyone? Okay, the person holding the mic with those. If you don't know, pass it on. Satish.
Onset shows etiology. It suggests etiology. Acute sudden onset maybe ischemic or vascular etiology. And
so onset is more, onset and course tells you etiology, what the lesion is, and what tells you where the lesion is in the neuraxis?
It's course and
not the course. Major
the pattern of involvement tells about the
pattern, or as in the neurological, the pattern of the neurological deficit. So in this slide, what forms the which section is the pattern?
The facial weakness and weakness of all four limbs defines the pattern.
That is the pattern of neurological deficit. Right? It is this pattern that tells you where in the neuraxis is the lesion, and the second half of the slide, onset and course, that tells you what the lesion is. For example, weakness of limbs can be due to parasagittal meningioma. It can also be due to GBS. It can also be due to poliomyelitis. So, what the lesion is defined by what is the onset and course. Thank you.
The patient was asymptomatic till 30th of October when he noticed deviation of face to the right while he was shaving and difficulty in rinsing mouth while brushing. He also noticed inability to close his left eye completely while he was driving when he had excessive watering and redness in the left eye. Further, he reported to AFMC Jodhpur, where he was admitted and managed as a case of Bell's palsy left-sided, and started on tablet prednisolone on 31st of October. After 3 days of treatment, he noticed he is not able to close his right eye also, and his family noticed a slur in his speech.
So at this stage, Major Prashant, so you've seen a pattern here. From this pattern, where do you think the lesion is?
It's a element type of palsy, facial palsy.
Okay. So,
sir, then the facial nerve, the course of the facial nerve.
Facial nerve. Anybody who can improve on this? Visual? Major visual?
It could be element type of weakness, so it could be from the nucleus.
Firstly, why are you saying it is element type of facial palsy?
Sir, he came with complaints of weakness.
The mic closer to you.
So he came with complaints of weakness of the entire left side of the face. That is including he was not able to close his left eye, as well as he was not able to. There was a deviation of face towards the right side.
So which part of this tells you that it is element?
Unable to close his eyes.
Close his eyes. So a person who's unable to close eyes is likely to be a low motor neuron kind of palsy. So he said facial nerve. Prashant said facial nerve. Would you like to think of something else also?
From the nerve, the nucleus, the neuromuscular junction as well as the muscles.
Neuromuscular junction as well as the
muscles.
So it need not just be the cranial nerve. It can be the neuromuscular junction and the muscle. For example, what do you think this is?
This is first one. And second one, B is a snarl.
Snarl. What is a snarl?
It is a kind of.
So here also there is a facial palsy,
Sir.
right? The woman, young woman, is not able to smile properly. Probably a facial palsy. So what do you understand by snarl? It's not looking like a normal smile, right? What is happening here?
So, the second one shows that there is a uplifting of the middle portion of the.
Yeah, so normally in a smile, you have like a smiley emoji. It curves upwards like this.
Yes, sir.
Here, there is no upward curve on the corners of the mouth. Rather, it's the middle portion of the lips that is going up. So this is a typical appearance of a snarl, and it is seen in myasthenia. So when we see a facial palsy, don't just restrict yourself, especially when you see bilateral facial palsies. Don't restrict yourself to facial nerve only. It could be a neuromuscular junction like a myasthenic snarl. Any other localizations?
It could be muscles like
Muscles like
facioscapulohumeral.
yeah, very good. So it can also be a muscle disorder like a facioscapulohumeral dystrophy, and many other muscular dystrophies can present with facial weakness. And here the problem is not in the nerve or neuromuscular junction; the problem is in the muscle itself. What is the difference between? How can you subtly pick up between the difference between two?
There will be a flat kind of smile which will be there.
Hold the mic.
There will be a flat kind of smile which will
Hold the hand steady.
flat kind of smile which will be there, sir. In
Yeah, it's called a transverse smile.
Yes.
Normally, in a normal smile, it is a smiley upwards, but in muscular dystrophy, the smile is transverse. So it's called a transverse smile. So myasthenic snarl, with the middle aspect of the lips, they rise in myasthenia, and a transverse smile in muscular disorders like dystrophy. Okay, carry on. And I've included this picture to tell you that whenever you're dealing with a suspected low motor neuron facial palsy, an attempt should be made to see whether lacrimation is affected or whether the patient has developed hyperacusis, as in he's hearing very loud sounds, or whether he's lost taste sensations, or finally, like in our patient, the patient has lost his power of the facial muscles. So based on this, you can actually localize. So if the patient has normal lacrimation but has hyperacusis, the lesion is somewhere here. But if the patient has no hyperacusis and no problem with lacrimation but has lost taste sensation, the lesion is somewhere here. And if the patient doesn't have loss of taste sensation, has no hyperacusis and lacrimation is normal, but only has facial involvement, then the lesion is somewhere here, the distal part of the facial nerve or beyond. Obviously, when only parts of the facial nerve branches are affected, then it's even more distal, and that may be a clue sometimes to a neoplastic infiltration.
Further, 3 days later, on 3rd of November, he noticed slippage of his chappals with knowledge and difficulty in breaking chapati, buttoning and unbuttoning his shirt. Over the next 5 days, by 7th of November, he noticed difficulty in getting up from the squatting position. His weakness further progressed over the next 2 to 3 days, such that he required support to stand and he was unable to change sides on the bed. There is no difficulty in lifting his neck from the pillow, and he complained of loosening of his limbs, and there is no history of wasting, abnormal flickering in muscles, and diurnal variation in his weakness.
So when we talk about upper motor neuron and lower motor neuron, this is the watershed line. Anything above the anterior horn cell is upper motor neuron, and remember that you can get weakness because paralysis, quadriparesis, paraparesis, all because of either. The weakness per se doesn't tell you whether it's upper motor neuron. So what do you think is the problem here, Parvinder?
It seems to be lower motor neuron.
And why do you say it is lower motor neuron?
There is a history of loosening of limbs.
Loosening. So typically, any lower motor neuron, which can be the anterior horn cell, the radical here, the nerve, neuromuscular junction, and the muscle. Any problem here leads to loosening of the limbs, wasting as in thinning of the limbs. Sometimes you get fasciculations. Whereas what happens if it is upper motor neuron?
Tightness and heaviness.
You may get heaviness, you may get tightness, you get spasticity, you sometimes get clonus, which is an involuntary to and fro movement of the limb when it strikes an object. So you think because of the loosening, the patient is likely to be having a low motor neuron? Okay, correct.
Further, there is a history of urinary retention with preserved bladder sensations. Post urinary catheterization, a large volume of urine came out. Subsequent attempt at removing the Foley's catheter failed because of urinary retention. There is no history of loss of sacral and perineal sensations.
So can anyone tell me what are the Lapidus classification of bladder dysfunction? Any volunteer? Okay, Abhishek, you have the mic.
According to Lapidus classification, we have 5 types of neurogenic bladders. First is the uninhibited bladder, where the cortical sensations are lost. Patient can have features of urgency and hesitancy and increased frequency. Sir. The second is presence of paralytic type of bladder, which can be either a sensory paralytic or a motor paralytic.
So you said the uninhibited bladder. The problem is in the brain.
Yes,
brain. So a typical feature of an uninhibited bladder is that they also lose the social awareness and they lack the sense of embarrassment. So normally, if the patient has a bladder problem because of the cord or because of the nerves here, they are acutely aware of this disability that they have and they become embarrassed at that. Whereas a patient with, for example, a frontotemporal dementia or a parasagittal meningioma may not be embarrassed about such a bladder voiding. So that is right. What happens when it is here? It's called a
reflex bladder.
It's a reflex neurogenic bladder. What happens with that bladder?
So both the sympathetic and the parasympathetic fibers are cut off. So whenever there is a filling of urine in the bladder, there is reflexly the bladder contracts and release the urine.
So
but the cortical sensations are still absent at this stage.
Yes, so sensations are absent, and it's a human bladder in the sense that the patient goes to the toilet very frequently, and he or she cannot control the urge to pass urine. So, like if the patient is sitting here in the auditorium, and if he or she gets the urge, he has to immediately rush to the washroom. Otherwise, there will be urge incontinence. So, this is a reflex neurogenic bladder. And what happens if you have a lesion here?
So in this case, then either they can be a paralytic type of bladder, so it can be a sensory paralytic bladder or a motor paralytic bladder.
Sensory and motor paralytic bladder happen if the sensory arm only is involved, you get a sensory paralytic bladder, whereas and this can be a large volume bladder. When the lesion is here, it's a small volume bladder. But as Major Parvinder said, when the Foley's catheter was inserted, a large volume of urine came out. So this is likely to be a retention and suggesting a large volume bladder. So the problem is likely to be either here, which is the conus, or the sacral segments of which is equivalent to the lower motor neuron of the bladder. So it can be a lesion here, it can be a lesion here in the sensory arc, or it can be a lesion in the motor arc. Now, Major Parvinder also mentioned that this patient had preserved bladder sensation. So it is. So where do you place that?
So since sensory arc was preserved, either it can be a motor paralytic bladder, can be a possibility at this stage.
Yes, so, as of now, I would place the bed somewhere here because the sensations are preserved. Bladder is large volume and there is retention. So either I would place my most likely here. Rarely there is a possibility that when you have a conus lesion, you may still find that the patient has a large volume bladder. Can the lesion be here and still cause a large volume bladder?
In case of autonomous bladder, when there is a parasympathetic fibers are cut off.
No. Anyone else?
In spinal shock.
Major Parvinder.
In case of spinal shock?
Yes, in case of spinal shock, suppose you get acute transverse myelitis, or the patient gets, for example, a trauma here, a road traffic accident causing a trauma or a bullet injury. What will happen is the initial few days or weeks, the patient will go into a spinal shock, and in that spinal shock, the bladder will behave just like a low motor neuron bladder with a large volume. But over time, maybe a month or 2 months down the line, it will become a spastic bladder in the